Hey guys, Woodruff here. So let's talk about blood transfusion. With blood transfusions, we used to give like whole blood, all the different parts, but now we actually break it into components. So usually now, when we're giving blood in the hospital, we're not giving whole blood. We're giving either red blood cells, we're giving platelets, we're giving the fresh frozen plasma or FFP, or we're giving what's called cryo or cryoprecipitate. We're going to kind of break down each of these, but it's just a good introduction to know how it used to be. So let's talk about each of these. And I don't want you to get too, like, you do not need to memorize these numbers when it comes to it, like how much it's going to replace. We would not give you a test question, at least in my school, about that. But it's more just to understand kind of what you're giving and why you're giving it. So there's what's called PRBCs, or packed red blood cells. These are used for blood loss because we're replacing whatever's missing. And again, we've talked about this in a few of these videos, but we usually transfuse for a hemoglobin less than 7. Know that 1 unit can usually increase a hemoglobin by about 1 point or 1 gram on your labs, or a hematocrit by about 3%. And if we're talking about actual volume, usually each of these are close to 500 milliliters, and that's how much volume they can replace if it's a volume loss. There's also platelets, and so the rest of them we pretty much give for bleeding and clotting issues. Platelets are given specifically for either someone who has low platelets, and depending on why the patient has low platelets, depends on when we would give it. So there's not a certain number. Everyone's a little different. I'll tell you, in my experience, usually we don't start replacing platelets till we're getting like low, like maybe less than 50,000, unless the patient's bleed. Like if the patient starts bleeding, we might give them less than that, or before that. I've given platelets when someone's platelets were in the 70s. So it just depends on the patient. But for some patients, like liver patients, sometimes the doctors don't want to transfuse platelets until their platelets are less than 20. So everyone's a little different. It's indicated for people that are having, like I said, it's either like if the patient's bleeding, so we know they're not clotting and they're bleeding a lot, we might give them platelets to help with the clotting process, or if their actual platelet count's low. It can increase the platelet count by about 5,000 and helps you to clot better. So sometimes we're not even trying to increase the number, we're just trying to help their ability to clot. So then there's fresh. I'm going to say that. I sound like I'm on some sort of a, what is it called? Grocery store commercial. Fresh. Fresh frozen plasma, FFP. This is used to treat either bleeding or, bleeding, but usually specific related to certain clotting deficiencies, and it increases your ability to clot. But specifically, what you're probably going to see it most often used for in the hospital is someone who comes in with a really high INR, or they're on warfarin and they took too much, or we need to reverse it. Sometimes they're actually just on a fine dose, their INR is normal, or not normal, it's therapeutic, but we need to do a procedure or something on them. We need to reverse their warfarin. So FFP is actually, and you'll need to know this for this exam, at least for us in where I'm at for cardiac, you need to know that when a patient has when a patient is taking warfarin, if we ever need to reverse it, one of the reversal agents, there is vitamin K, but also fresh frozen plasma as well is another reversal. There's also what's known as cryoprecipitate, or we just usually call it cryo. And this has a whole lot of clotting factors. So we usually use this for people that are having, mass transfusions or bleeding after surgery. We do it for a lot of traumas. It's what do you call it? It's a part of our MTP, or massive transfusion protocol, at the trauma hospital that I work at. We give it for patients that just have severe bleeding issues. So it helps them. It doesn't necessarily increase a certain number versus helps them to stop bleeding so much, helps them to clot better. So let's talk about the blood administration procedure. So what do we need before? So as the nurse, I'm in charge of making sure that this is done safely. So there's some things that we need to do first. So first is consent. Now I'll tell you this, it is not my job as the nurse to actually obtain the consent itself. Now you're going to see some hospitals where nurses are getting consent for blood, but really the doctor has to talk to the patient first, talk them through the pros and the cons. As a nurse, I'm not supposed to be telling a patient about the risks and benefits of a medical treatment. That is the doctor's role. I can reinforce stuff or answer questions, but if a patient's having a bunch of questions about something that's about to be done or a possible side effect, I'm usually calling the doctor and saying, hey, you need to come talk to this person. So we want to get consent from the patient that they are agreed to have the blood. But it's my role as the nurse to check that consent is present or that they've signed consent. And a lot of hospitals now are going to, when you come in, they want to see right away if you have, a lot of people have, certain feelings about receiving blood products. We usually like to ask that early on in case there is an emergency, that we're not going against the patient's wishes. We also need to get IV access. So you'll hear mixed literature about this. Effectively, we prefer a patient to have an 18 or a 20 gauge to give blood. We absolutely can give blood through a 22 gauge. It would have to go super slow, not super slow, but it would have to go slower, and we can never, put it through like a rapid transfuser. If I need to rapidly transfuse blood, it has to be an 18 gauge, usually something bigger. But keep in mind, we're not going to go that in depth with you guys. Just know, like, we need IV access because that's how it goes in. It goes in straight through our blood. We usually prefer 18 or a 20, but it can be given, 22. It's like if a patient comes into the hospital, I use this example, I'm sure, in my other videos, but if a patient comes into the hospital and they're bleeding to death and they need blood, I'm not going to be like, oh, only can get a 22. Sorry, no blood for you. Like, we're going to make it work because they need the blood. We also use a special tubing set that's displayed in this picture. This is what's called a Y-type tubing set. It has a filter in the middle. Blood is super thick, and so it can easily clot off when it's just sitting in a bag. So it has special tubing to make sure that the blood does not clot as easily or clog, and so we can give it safely. So we do this Y-type tubing set. On one side is saline, and it's important to note that blood can only be given with normal saline. No other IV fluids are compatible. But there's usually normal saline on one side, the blood bag's on the other. And the purpose of that is that I can start giving the blood. And then when the blood's done, then I can clamp the blood on the one side of the Y. And then on the other side, I can open the saline and then flush through. Or if there was an immediate issue or problem where I needed to start flushing through, flushing that IV, flushing through that, I have that saline bag open and ready. The procedure for administering blood, it may vary by hospital system. But overall, we need to do safety identification checks. We do a 2-nurse sign-off. Effectively, I usually either send someone or go myself, go get the blood. It's a sign-off at the blood bank. Then they need to, once it's released from the blood bank, they have 30 minutes. I have 30 minutes to give that blood product. I need to get a baseline set of vital signs before usually the blood's even on the floor, or right before I'm about to give the blood. And then again, I need to give it within 30 minutes, or I need to send it back to the blood bank within 30 minutes, or it will go bad and I cannot use it. I need to do that 2-nurse sign-off as we are hanging the blood, make sure that I have the right patient, the right blood type, and all that stuff, and doing multiple checks, making sure I have the right tubing, right fluids, and that I have the IV access that I need. That's not, you don't have to do all of that with the 2-nurse, but I'm just telling you, these are all the verifications. Then I'm going to stay in the room with the patient for the first 15 minutes to make sure they're not having an acute reaction. If someone's going to have a really bad reaction to the blood, it's usually going to be within the first 15 minutes. If they're having temperature issues, or if we need to give it rapidly, we may want to use a blood warmer. And it's a machine that we actually put the tubing through, and it warms it through the tubing and then into the patient. Helps to decrease, because blood is kept in a fridge, and so it's cold. The transfusion, how long we do it over, your textbook talks about usually on average about 2 hours. Everyone's a little different, depends on what kind of unit you're in. Most blood in the ICU, we give a little bit more quickly. It just depends. You can give it by gravity, you can give it by pump, but it should not take longer than 4 hours. If you let it sit out that long, it increases the risk that they can get septic or have bacterial growth in that blood. So let's talk about now the big hot topic for blood transfusions. Now let's say that we've safely, gotten the blood ready together and into the patient, it started going in. There's not a high chance, excuse me, let me take that back. There is a chance that the patient could have a blood transfusion reaction. We are always watching for this. These can happen myself have never experienced a blood transfusion reaction. And when I say that, I feel like there's maybe one time, but nothing is sticking in my brain. I'm getting old, but nothing's sticking out right now. I feel like there was maybe this one time we weren't sure, but it wasn't anything like for sure. Maybe it was just that they had a fever. I can't remember. But you have to go through a whole process if there is a blood transfusion reaction. We'll talk about the process later, but there's a variety of types of transfusions. But first we need to understand, why would someone react in the first place? Your body sometimes can say, hey, this blood's not mine, and kind of reject it. Sometimes the body's reacting that it's a whole lot of fluid or volume very suddenly. There can be something in the blood, like infection, that the body is reacting to in the blood. And we can prevent a lot of these by making sure we're giving the right blood to the right patient, doing that 2-nurse sign-off, and then close monitoring before, during, after, to look for these changes. So coming next is a bunch of back-to-back types of transfusion reactions. So I know it's going to be a lot. Just try to look for what's different between these, and then we're going to do some case studies at the end. So first, let's start with one of the most serious types of reactions that a patient can have. It's what's called an acute hemolytic transfusion reaction. And so pretty much what's happening here, lytic, think like lysis. It is a hemolysis, or a breakdown of red blood cells. I always do this analogy, so get over my analogies if you hate them. Here they are. They're not going anywhere. But pretty much what happens is the blood cells come in, your body's like, this is not mine, kill them now. So I always think of like Darth Vader and lightsabers and Star Wars and all this stuff, where they come out with the lightsabers and they just start slashing the blood cells. This is my mind. It's creative. It helped get me through nursing school. So, hopefully it'll help you too. But I just imagine this blood's going in, the body's like, not mine, kill it quickly. And so they get their lightsabers out and they start slashing all these blood cells. Usually this happens fast, like within the first 15 minutes. The body's not going to see like, oh, there's something coming in, I'll react in an hour. It's going to react right away. Some of the cues that you want to look for that are going to be different and some of these you might see for multiple, so pick up on which ones are different as we're going through. That can have an increase in temperature, a decrease in blood pressure, shortness of breath, back and chest pain, low blood pressure, high heart rate, like shock. I have low blood pressure twice, don't mind that. And kidney issues. So this is a very serious reaction. And what you want to think about, looking at these cues, how it makes sense is there is effectively this slashing of blood cells. So what's going to happen is they're going to start to clump together. And that's where you have the dyspnea that's literally starting to clog in my airway. What do you call it? Like, not in my airway itself, that sounds bad, but like in the blood vessels to my airway, which makes it hard to breathe. I can have back and chest pain because it's literally like little ischemia or ischemic, emboli that are going around. You're going to shock because your body is killing all these blood cells, and there's this massive decrease in volume very quickly. And then the kidneys, same thing, where there can be kind of almost like micro clots or clogs leading the blood vessels to the kidneys. But on top of that, the kidneys are also your filter. And so as your body is trying to say, get rid of all this stuff, it's not ours, it can get very overwhelmed. So what you want to do, this is one of those that you stop the transfusion. You will never restart a transfusion for a patient with acute hemolytic. We're going to talk about other transfusions where possibly, if they're doing okay, you might be able to restart it, but this is not one of them. We're going to draw blood samples to identify that it actually was hemolysis. So what we usually do is we take the blood that we were given, we take blood samples from the patient, the tubing, everything, we send it all down and send it to the blood bank, and they do testing on it. You want to keep the IV line open. So this is a common thing that students mix up. We talk about phlebitis. Phlebitis is where there's irritation of the blood vessel. If my blood vessel is irritated, absolutely, I need to take that IV out. There's no blood vessel irritation here. This is a cell level destruction. I need an IV line. My blood pressure's low. I'm going into shock. I need to give this patient fluids. I need to, when there's all this accumulation of these little micro clots or like clogging of these blood cells that's causing blockages everywhere. It's overwhelming my kidneys. I need fluids. All of those things lead to I need fluids. So I need to disconnect the blood, but I need to get IV fluids running, flushing through this IV. So do not remove the IV. Remove the blood from the patient, not blood from them, but remove the blood line from them and just give them IV fluids. and help to kind of flush out some of that excess breakdown of cells. And then I'm going to support their shock state, like their blood pressure. Again, IV fluids, they might need more stronger meds. You don't have to know about those. And really my assessments and management is going to be all around kidney function for these patients. All right, so there's also what are known as febrile transfusion reactions. So this one is very simple. The only thing that's really happening is they get a fever. So it can be that they usually have a sudden onset of chills, fever, their temperature rises greater than 1 degree Celsius. This one you're going to see it for everything. Every single one, we're going to stop the transfusion. We're going to stop and assess. With hemolytic or, the transfusion reaction, we are not restarting it. With this one, it's possible. We can talk to the doctor. We can give some antipyretics and see if they want to restart. It kind of just depends on the patient. And sometimes in the future, if a patient has febrile reactions, they're maybe more likely to have another one again. So sometimes what we do before we give the blood is we give them an antipyretic like prophylactically or prior to. All right, so for allergic transfusion reactions, there's 2 types. There's a mild reaction. So I kind of think of like allergic rhinitis kind of reaction. I should say not allergic rhinitis because it's not in the nose, but I would say like topical hypersensitivity, and then severe like anaphylaxis. So mild allergic transfusion reaction is going to be flushing, itching, rash, hives. And we're going to do the same thing that we talked about for hypersensitivity. We're going to stop it and then give things to help treat the overreaction of the body. So antihistamines, maybe steroids, things like that. I'm going to get severe. They're going to have all the signs like we talked about in the last section that have to do with anaphylaxis. So dyspnea, wheezing, shock, and go into cardiac arrest. We stop it and then we treat it like anaphylaxis. And if you remember some of those, prior to your key treatments, it's going to be like oxygen, epinephrine, bronchodilators, steroids, diphenhydramine, or Benadryl, antihistamines, things like that, oxygen therapy, IV fluids, that kind of stuff. I know, stick with me. There's only 3 left. So there's also what's called circulatory overload. So this is a reaction where your body, it's too much too fast. It can't handle it. It's too much overload. This is especially going to be more common in patients that have heart and kidney problems. They have problems managing fluid. If someone has heart disease or kidney disease, they have a fluid management problem, or they're going to have trouble dealing with a lot of fluid at once. So what are you going to see in this patient? Well, you're going to see signs of fluid overload. A lot of this patient's going to look like a heart failure patient. Look, isn't it cool how it all connects? It's so exciting. If you haven't learned about heart failure yet, it's coming. Anyway, so shortness of breath, kind of like wet, coarse lung sounds, bronchi, that kind of stuff. It's going to sound, they're going to have signs like where you can hear fluid in their lungs. The lungs are one of the first places where fluid shifts occur. So if I have too much fluid, one of the first places my body tries to offload that fluid is my lungs. So listen to lungs. High heart rates, they have high blood pressure because volume is pressure, and distended neck veins. So it's the point, like, think of like, I call them little ropes, but like your, what do you call it in your neck? Your garden hoses in your neck. They get really thick. They're distended. They're full of fluid. So as the nurse, I want to sit this patient upright. It's going to help with their breathing, and it's going to help to, we call it decrease, like, anytime that there's too much fluid in something, we elevate it. So this is what we do. We usually, as prescribed, will do other treatments like chest x-ray to see how the lungs are looking. We're usually going to give things like diuretics, and oxygen as well, and as needed to support. Now, with these patients, they're not actually reacting to their blood, they're reacting to the volume. So usually what I have to do is just slow down. I just have to give it a slower rate. So I'll tell you this, is if I have a patient, I've had patients that have heart failure that need blood. And what I usually do, and this is what the doctor ordered, it's not what I decided because I'm not some sort of, evil genius, but this is what the doctor ordered, is that I gave 1 unit of blood, I gave a diuretic, and then I gave another unit of blood. Because a lot of times when I'm replacing blood, I'm not always replacing volume. A lot of times I'm literally just replacing the cells. And so if I'm giving a unit of PRBCs, I'm really just trying to get those red blood cells. So in other words, what I'm saying is this patient, they needed the red blood cells. They didn't need the fluid that came with the red blood cells, but I can't give just the cells. The fluid comes with it. So, with this patient, what we did is we pretty much gave the first unit of blood, gave a diuretic, let them kind of calm down, catch up, and then gave them the other unit of blood. But usually with these patients, like whereas other patients, I might let, the blood go in pretty quickly. I usually want to go at a slower rate for these patients, especially if I know they might be at risk. I still need to stay within that 4 hours, but I'm probably going to stretch it out a little bit more versus what I might do with a patient that does not have those risk factors. Then there's sepsis, which is where like effectively there's some sort of bacteria in the blood. Now this could be something that I did, like I said, maybe I hung it for too long. I waited for too long to get it started, something like that. Or it could be, we test all of our blood. This is not something that happens often, but it's always possible that something could be in the blood, or maybe the way that I was administering it, et cetera, could go on. So this is going to look a lot like some of the other stuff we talked about. It's going to look kind of like hemolytic, where there's the fever and the low blood pressure. But what's going to be different is we're going to see that they have an elevated white blood cell count and other signs of infection. Usually they're going to go kind of into a shock state where their blood pressure is low and their heart rate is high. We're going to do things like get blood cultures to see what's growing. We're usually going to give them antibiotics to treat whatever's growing, IV fluids to flush out that bacteria, and then also get their blood pressure up. And then if needed, we give what's called vasopressors. These help to constrict my blood vessels. Sepsis is a type of vasodilation shock, which you'll learn about when you get to complex. It's coming. So you don't need that much about vasopressors, but just know that they help to bring your blood pressure up when you're in that shock state. All right, last but not least, massive transfusion reaction is where you just had so much. So like these are people that come in that have to get like the mass transfusion protocols, or just are very anemic, have had a lot of blood back to back to back to back. What this is going to look like, if I've had a lot of blood transfusions, I've also had a lot of cold administration. So a lot of times these patients are hypothermic from all of the very cold blood or refrigerated blood going into them. They also have, because of what is put in blood to help preserve it and things like that, they can have high levels, they can have low levels of calcium. It kind of, blood products leach your calcium. They also can have very high potassium as well. It can go low too, but usually we see high potassium, low calcium, which can lead to dysrhythmias and very serious stuff. So what are we going to do? We're going to warm the patient, make sure the other products we're giving them are warmed. We're going to treat their electrolyte balances, keep them on EKG monitoring, ECG monitoring to look for dysrhythmias or other complications, and monitor those electrolytes closely. All right, so those are all the different types of transfusion reactions. Let's talk about our priority response. We want to stop the transfusion in all of these. And I should back up a little bit, going back. Let me see here. So like we talked about this one we're going to stop, not restart. This one we're going to stop. We may restart, or we may need to, like in the future, just give them something prior. This is the other thing I wanted to mention is for allergic, for mild, if I know, because sometimes people just have a mild reaction to all blood, no matter what kind of blood it is, what kind of product it is. So they might just need in general, like this one is one where I'll probably stop to make sure that they're not having a very severe reaction. And then per the doctor, they might restart it after I give an antihistamine or a steroid, and I might know for the future I need to do it. Now, if someone has an anaphylactic reaction, I'm not restarting that, obviously. Like I said, for circulatory overload, I can restart, but maybe slower per the doctor. And septic, I'm not going to give potentially bacteria-infected blood back to someone. So we're going to stop it and treat the infection. And then mass transfusion, it's like from too many products. It's not the products themselves that are the problem, it's just too many. So we're obviously going to try to limit how much blood, but if they're receiving blood at the time, it's going to just be up to the doctor what they want to do about continuing that. All right, so as a whole, we're stopping the transfusion. We're going to keep our IV line patent with a saline solution. So that means we're going to run that saline through and make sure that we're giving them good IV fluids that, helps dilute a lot of the problems that we talked about, keeps their blood pressure stable, and helps support their kidneys and other organs that need that flow. We're going to notify the blood bank and the healthcare provider. We're going to recheck everything, make sure that we gave the right blood, look for what issues might have happened, look at vital signs, urine output, because the kidneys can be strongly affected by this. Whatever our symptoms are, we're going to treat them per orders or whatever is prescribed. We'll save the blood bags in the tubing and usually send that to the blood bank for testing and collect any required specimens, and then document or CYA, chart your ass off. Maybe CYAO. Chart your ass off. I always hear people say CYA. So Something else, like I mentioned, something to keep in mind is some religions do not accept blood transfusions, and that the patients and people that are designated as their decision maker can make the decision to refuse care if they're competent. But there's a lot of ethical stuff in here when it comes to kids. There's a lot of ethical things that come up, and they bring it to ethics teams, etc. When there's these really difficult situations. There's many people that have it as a religious thing, but there are some people that are just really, they have old ideas about what blood transfusions are or what we do with blood transfusions. A lot of times people think the blood's just dirty, that we don't test it. So it is good to, I always ask people, and I was like, oh, can you tell me a little bit more about your feelings around this? Just to make sure that they're properly educated. I'm not trying to change their mind, but I just want to make sure that they have all of the information that they need to make a decision that's best for them. It is a hard part sometimes, seeing a patient who there's like a life-saving treatment they can get, but also respecting that to you're thinking death is the worst thing for them, but to them receiving the blood may be worse than death based on their own religious or other beliefs. So just keeping that in mind and leaving your bias at the door. All right, so let's do some case studies over these blood transfusion reactions. So each of these is a different type of blood transfusion reaction. Let's see if we can break it down. So this one is John. He started receiving a blood transfusion. After a few minutes, he starts itching and is feeling flushed. His vitals are stable. So right now I know that he is not having any sort of like major imbalance, but he's just itching and feeling flushed. So that sounds like what kind of transfusion reaction? I was going to do a drum roll, but I don't have a drum here. Maybe, I don't know how loud that is or how much that's really going to help. It might sound very anticlimactic. It is a mild allergic reaction. So itching, feeling flushed, no other problems. It sounds like he's having allergic reaction. What are we going to do about it? So what do we do for mild allergic reactions? Well, we can give medications to treat the allergic response, like antihistamines or steroids, or and we might be able to restart the transfusion, or the doctor may decide to hold off. We also want to be looking for any worse signs that they're reacting worse or going more into like a full anaphylaxis. All right, number 2, Sierra started receiving a blood transfusion. Here are her vitals. We'll look at them in a second. Oh, never mind. No, that's all the story. We're going to look at them now. So her blood pressure prior to a transfusion was 118/77. Now it's 120/80. Okay, well, that's not bad. That's fine. Heart rate was 100. Now it's 98. That seems okay too. Temp was 98.9. Now she's 101. So from this data, you have to look at what's different. The only thing that's really changed and significantly is her temperature being elevated. So what reaction? Everything else is fine, but they just have a temperature. That is right. If you said it's a febrile reaction. So this is a where everything, everything else they're not reacting to, their blood pressure, heart rate, everything's fine. Only thing that's wrong is that they have a temperature. So we usually treat them with antipyretics and, usually prophylactically treat them in the future if this is a common occurrence for them. All right, Marianne, she's received 2 units of blood over the last hour. She has a history of heart failure. She did not have an immediate reaction to the blood, but now is coughing, short of breath, has JVD, which is jugular vein distension, and she's tachycardic, so her heart's racing. What type of blood transfusion reaction is she most likely having? So she has a history of heart failure. She's coughing, short of breath. She has signs of fluid overload, and her heart is racing. So I would expect that Marianne is having a circulatory overload reaction. So it sounds like she has too much fluid, especially with her history of heart failure. I would also expect her to have maybe coarse lung sounds. And to treat her, I would sit her up. I would probably get some diuretics ordered. Maybe, what do you call it? What was I going to say? Diuretics ordered, head of bed elevated, maybe do a chest x-ray. And I feel like there's something else I'm forgetting. Why is my brain in a crazy thing? Oh, oxygen, duh. Silly Mrs. Woodruff. Oxygen therapy to support her breathing. Don't mind me over here. All right, number 4. Sean receiving a blood transfusion. A few minutes after his blood transfusion has started, he begins to feel back and chest pain. Here's his vitals. So he started out at 125/77. Now he's 90/40. Started at a heart rate of 90. Now he's 125. Started at a temp of 99. Now he's 101.4. So it looks like he's got a decrease in blood pressure, increase in heart rate, and an increase in temperature. What does he most likely have? Thinking also that he has back and chest pain as well. So this sounds like a hemolytic transfusion reaction. So this is usually, again, a result. It's that quick one that usually happens in the first 15 minutes where their blood cells start doing the Jedi tricks and breaking down other blood cells because they say, this is not mine, you are rejected. Other symptoms that he may be experiencing, remember, we want to look at the kidneys, how the kidneys are functioning. They also could be having shortness of breath. Things like that as a result of those microclots. Let's see if there's anything else I want to ask. Yeah, I think that's it. And then priority assessments and interventions, watch the kidney function. Obviously, stop the transfusion. IV fluids to maintain that. Tell the doctor, I need to do all the things to verify that it was a hemolytic reaction. I'm going to do things to support their stability and prevent further shock. All right, case study number 5. Gregory is receiving a blood transfusion. Within a few minutes, he begins to feel short of breath, chest tightness, wheezing, and hypotension. What is going on here? It looks like Gregory is experiencing anaphylaxis. So yes, if you got that right, I'm so proud, if you remember from the first section. So anaphylaxis is what Gregory is experiencing based on these signs and symptoms. And so what are my priority treatments? So we kind of talked about this already, but remember, first and foremost, epinephrine to open that airway. Then we do things like bronchodilators, inhaled steroids, oxygen therapy, fluids, diphenhydramine or other antihistamines. We want the patient to stop reacting. We want to keep their airway open, and then we want to treat any shock that may be going on. We're almost there, guys. You're doing great. So Samuel received 2 units of blood earlier today. He is now developing chills, vomiting, and a high fever. His current vital signs are as follows. Blood pressure, 76/54, heart rate of 130, and temp of 102.3. So this looks like he's got a shock state. This looks a lot like the last patient. High heart rate, low blood pressure, high temperature. But the only difference here is the other one was within 15 minutes. This said that he had red blood cells earlier today. Now he's developing chills, vomiting, and a high fever. So this sounds most like septic reaction. So he's getting an infection and going into septic shock. So we are going to treat him by doing blood cultures, getting antibiotics. We're also going to maybe give some IV fluids to help to hydrate him, get that blood pressure up, and if needed, we'll do vasopressors. We might give some acetaminophen for that fever. But yes, we're going to treat the infection and then treat the shock as well. All right, last but not least, Henrietta, she had a serious car accident earlier today, and she has to receive 8 units of PRBCs, 4 units of cryo, 2 units of FFP, and 1 unit of platelets. She states that her heart is fluttering, and feels very weak. Her vital signs are as follows. Her blood pressure, stable, heart rate's a little elevated, temperature, 95, that's a little low. Labs were ordered and reveal the following. Her potassium is 6, and then her calcium is 5.5. So what do we think is going on? High potassium, low calcium, low temperature, high heart rate, heart is fluttering. What could we be? We are massive transfusion reaction. So that is, again, where they've had so many blood products. That's the cue in your question. Always look at the story in the case study to kind of cue you and see what in this story leads me to think that this is the best possibility or the most likely possibility of type of reaction. So the high heart rate, because she's probably having dysrhythmia. Low temperature is a big thing here. Remember, all the other ones, they have a high temperature. This one has a low temperature. And then that high potassium, low calcium are all ding, ding, ding signs I've had too many blood products. So we're going to treat these electrolyte imbalances, warm her up, and she should stabilize once we get those electrolytes and temperature back in balance. So that is blood, hematological, blood disorders, anemias, all the fun things and blood administration. Hopefully you had fun with this lecture. I'll see you for more cardiac soon.